Good morning, good afternoon, good evening, everyone. My name is Girija Sankar, and I am with Children Without Worms, or CWW. We are thrilled that so many of you have been able to join the STH Coalition webinar today. We are at about 43 or so participants, and so it feels like a good time to kick things off. So CWW is a key partner in STH elimination, intervention, scale-up, and operations research. And we often facilitate technical meetings and seminars on current topics in STH control and elimination. And in our role as the host of the STH Coalition, we provide STH partners a forum to present findings from recent research and experiences and lessons learned from program implementation. So we're very excited to host today's webinar on STH operations research in Kenya. We have colleagues. I'm going to move my screen ahead so you can see what's coming up on the agenda. We have colleagues from Evidence Action, the London School of Hygiene and Tropical Medicine, and of course, Children Without Worms, presenting findings from recent work in Kenya. We're also very delighted to have Dr. Sultani Matendechero, head of the Division of Vector-Borne and Neglected Tropical Diseases, Ministry of Health, Kenya, and a member of the STH Advisory Committee, who will serve as the chair of the webinar today. A few housekeeping notes before I hand over to Dr. Sultani. Please consider turning your videos and definitely your microphones off during the course of the webinar over the next 45-50 minutes or so. We will open up the session for Q&A at the end of the three presentations. So please do feel free to make note of your questions for the various presenters. And then when you do have a question to raise, please use the chat feature to ask questions of the presenters. You should have a chat box available in the Zoom meeting. So please use that at the end of the three presentations to ask questions of the presenters. I will read the questions out, and then I will invite Dr. Sultani and the presenters to weigh in. We will be recording this webinar so that we can throw it up as a resource on the CWW website. Finally, if you wouldn't mind sharing your contact details, I've put in a note on the chat feature asking you to share your contact details to my email. I would greatly appreciate it. And so, Dr. Sultani, I invite you now to say a few remarks and then hand over to the presenters. Thank you.
All right, thank you very much, Girija, for that very comprehensive, although brief, introductory remark. As Girija has told you, my name is Dr. Sultani Matendechero. I work in the Ministry of Health in Kenya and at the Division of Vector-Borne and Neglected Tropical Diseases. Now, today, as you already know, we are going to be looking at some research work that's been conducted in Kenya, around STH control. And just to remind you that as programs, we depend a lot on operational research, on scientific research, the findings to be able to inform some of our policy decisions and also to improve the approaches that we employ in ensuring that our programs are able to achieve the goals that we have set out to achieve. Now, in the interest of time, I'm going to move very quickly to allowing our presenters to come in and make their presentations. As you have been told by Girija, we are going to have three presentations. The first one will be by Andrew Kitchel of Evidence Action, and then I will have Hugo Legge, who will come in with another presentation, and then we will finalize with Sanjaya Dhakal from CWW, who will also give us a presentation. And these are going to form the basis on which we will have a Q&A, maybe so that we can be able to discuss and internalize a little bit more from those research works that we are going to hear about. So without any further ado, please allow me to introduce to you Andrew from Evidence Action. Andrew will be taking us through a presentation on coverage validation during COVID-19, an innovative approach. Remember, we are now grappling with COVID-19. And so this is going to be, a very informative presentation, because it gives us a very good platform to discuss the practical issues around how we are going to restart our programs and ensure that we don't fall back on the gains that we have already made. So Andrew, if you're ready, please come on so that you can make your presentation. You have 15 minutes, and then we will move on to the next presenter. Thank you very much.
Thanks very much, Dr. Sultani. Let me get this shared. Great. All right. Well, thanks again, Dr. Sultani, and thanks everyone for joining today, and to the STH Coalition for allowing us to present. Today I'll be speaking about a recent activity undertaken by the Deworm the World initiative in Kenya to conduct coverage validation after school closures and lockdowns were imposed in Kenya due to COVID-19. My name's Andrew Kitchel, and I'm the analytics manager of the Evidence Action Monitoring, Learning, and Evaluation team, with whom I work on M&E design, systems, and analysis. So the Deworm the World initiative is one of the flagship programs at Evidence Action, supports government deworming programs in Kenya, India, Nigeria, and Pakistan to implement school-based deworming that reaches over 260 million children annually. As part of our technical assistance, we provide monitoring and evaluation to support to identify opportunities for program improvement and course correction. This includes process monitoring, including observation and monitoring of training and deworming implementation, as well as coverage validation. Coverage validation is implemented by Deworm the World after each round of MDA to evaluate treatment coverage data that's collected at schools on deworming day. Coverage validation usually takes place about 2 to 4 weeks after the MDA and consists of a coverage evaluation survey based on the WHO guidelines that involves in-person interviews with children at schools and in their communities around the sampled schools to determine if they received and ingested the medicine during the MDA. The results of the CES are then compared with government treatment data to evaluate these rates and to understand areas for improvement. So the first wave of deworming in Kenya for 2020, and about half of our targeted counties in Kenya, took place on March 11th, 2020, after which coverage validation was planned to take place about 2 weeks after. However, due to the COVID-19 pandemic, school closures took effect less than 1 week after the MDA. And so we decided to postpone the coverage validation and determine the best path forward. Because coverage validation involves in-person interviews, some of which take place during school, we opted not to send enumerators into communities and schools to ensure the safety of those communities and of our staff. As a result, the team designed and deployed a new strategy for coverage validation in April, a phone-based coverage evaluation survey. The phone-based survey had the goals to evaluate reported coverage and to inform program learning on remote collection opportunities during the COVID-19 pandemic and afterwards. We sought and received approval from the National School-Based Deworming program government structure, which ensured that we could effectively reach out to teachers and communities. And we believe that Kenya was an ideal geography to pilot this phone-based strategy, because there's high mobile phone penetration, because the NSBDP is a well-known and trusted program, and because the Deworm the World Kenya team has been operating for many years and has context-specific data collection experience and access to data through the staff and history of the program in Kenya. So interviews with this new methodology, interviews were conducted with children's parents who would ask survey questions to their children due to challenges and sensitivity around speaking directly with children. The survey was adapted from the in-person household coverage evaluation survey that we have conducted in the past. And while we removed certain questions to shorten the length of the interview over the phone and keep the calls under 30 minutes, we kept key questions and sort of the key indicators of interest, such as demographic information, the type of treatment, program reach and surveyed coverage, as well as unprogrammed deworming. The survey sample consisted of 2,250 parent interviews from communities surrounded the most attended schools in 30 randomly selected communities in Narok and Siaya counties for 60 total communities. The subunits were, like I said, from Narok and Siaya, both of which treat for STH, while Siaya also treats for schistosomiasis. The parent contact information was gathered through teachers and other parents using a non-random snowball sampling method, where we were able to gather parent contact information by speaking with teachers at the schools in these communities, gathering contact information for parent-teacher associations and school boards of governors, and using those contacts to reach further parents to conduct the survey. And in addition, all respondents to the survey were given airtime credits as an incentive for completing the survey. In order to reach the desired sample of parents in each community, we knew that there were certain biases that we would be grappling with this adapted methodology, such as recall bias, selection bias, and social desirability bias. We grappled with these challenges when designing this new methodology, and we're able to remedy some of the expected challenges with bias based on our data collection. With recall bias, because the phone survey was conducted later after the MDA than normal, we expected that this could be an issue, both because of speaking with parents and because of the time that had elapsed since the MDA. So we attempted to account for this by training data collectors to encourage parents to ask their children who are present in the home for specific details about deworming, and also to encourage them to respond to questions that they didn't know if they were unsure. Further, for selection bias, we attempted to account for this by encouraging the contacts we made to share contact information for parents of enrolled and non-enrolled children in order to achieve a sample more representative of the community, of our targeted communities. And for social desirability bias, which is over-reporting of normative or desired behavior, we found it difficult to account for this bias without another round of the survey, which we're looking into right now. But we are working on analyzing the results in conjunction with government treatment data to try to best understand how this bias may have played out. So the survey was conducted during the month of May, and we received results in June and conducted data analysis and reporting. Some of the results are here. First, that parents were receptive to the phone-based survey, and the response rates were positive. 83% of interviews took place on the first call without having to attempt multiple calls back. About 15% of the children whose parents responded to the survey were non-enrolled, which ensured a robust non-enrolled representation, as they are part of our target population. And 95% of parents reported that all their children were present in the household at the time of the interview. The surveyed coverage for STH across the 2 counties, that is the rate at which parents reported that their children received and swallowed the deworming medicine on deworming day, surpassed the WHO threshold of 75%, suggesting that the deworming for STH was successful in these 2 counties. 84% of targeted children were offered the drug across the 2 counties, and 83% of targeted children reported to swallow the drug. The results from the remote coverage evaluation surveys were consistent with previous treatment coverage rates in these 2 counties. In Cara County, the average coverage rate in the previous 7 years of the program was about 82%, and the coverage validation rate from the phone survey was 83%. Similarly, in Sanjaya, the average was about 79% over the last 7 years, and the rate from the phone survey was 83%. So it's important to note, though, that while comparisons with the historical data are not, they are comparing different data sources, and therefore aren't conclusive. They do suggest reliability in this new approach, and we're continuing to work on analyzing the reported treatment data from 2020 to best understand the reliability of these results. So, as mentioned, this methodology was undertaken to ensure social distancing and safety while still being able to gather and evaluate treatment coverage during COVID-19. But perhaps more importantly, it presents a very cost-effective method to evaluate treatment coverage, pending the further analysis and testing that I mentioned. When we designed this methodology, the cost comparisons of in-person coverage validation compared to the phone-based survey in Kenya resulted in a large decrease in expected cost. The expected cost of the phone survey, even with the incentives we offered to respondents, was about 62% of our normal cost for an in-person survey, and the actual cost of the phone survey after we were finished resulted in only about 20% of the 25%, of the in-person survey cost. Travel, accommodation, field data collection costs largely contributed to the overall reduction. Largely contributed to that overall reduction. And in the table here, you can see the sort of cost comparison of our expectations and experience from in-person coverage validation as compared to that conducted over the phone. So based on the results from the comparison of historical data and the review of potential biases, the implementation of the pilot was largely successful, which is a positive sign for the use of remote monitoring strategies. And like I said, we'll continue analysis of the results in conjunction with government treatment data as it's received to further understand the estimates generated by this pilot. But we believe that replicating the methodology in other geographies requires certain conditions to produce a comparable degree of success. The first is high quality data. This pilot used data collected over 8 years of program implementation. which significantly impacted our ability to make contact with teachers and parents and was necessary to conduct historical comparisons. The second is partner relationships. We've established a strong relationship with the Kenyan Ministry of Education, which streamlined the approval process and allowed data collectors to leverage the partnership during phone interviews. The third is technology. As I mentioned earlier, sorry about that. Kenya has achieved a significant degree of mobile phone penetration, which was crucial to conduct phone surveys and eased achieving target samples and reduced non-response rates. Fourth is community trust. The Kenya National School-Based Deworming Program has been implemented in Kenya for 8 years and is well known and trusted by communities, which likely increased the participation of parents during the survey. We believe that the results of this pilot suggest a lower cost and lower barrier opportunity for coverage validation for STH programs in other geographies. This is a potential option for low funding or low technical assistance MDA programs to evaluate program reach and coverage rates after MDAs. Could also provide a venue for more government ownership of coverage validation processes with potential for government owning coverage evaluation surveys. In addition, the Deworm the World initiative is already planning on the iteration and continued evaluation of this approach, not only for during the ongoing COVID-19 pandemic, but also as a cost-effective coverage validation option moving forward. The program is currently planning for upcoming MDAs in India, Nigeria, and Pakistan, and we'll be adapting this pilot and the lessons learned from it for those geographies. This will provide an opportunity to understand and learn from the contextual differences across geographies and to develop a more generalized framework for remote monitoring. So as far as next steps go, as I mentioned, the Deworm the World and the Evidence Action Monitoring, Learning, and Evaluation teams are currently working to develop an expanded process monitoring and coverage validation toolbox adapted for remote monitoring during the ongoing COVID-19 pandemic. Based on the implementation success of the remote coverage validation survey in Kenya, we're looking to adapt these practices and lessons learned for process monitoring of deworming training and deworming day delivery. We're currently exploring if the information that we were able to gather in Kenya, contact information, teacher and lists, etc., will be possible in other geographies. And we're also working to determine if our ability to find parents and children together at a high rate during the survey, as was the case in Kenya, was unique to the strictness of COVID-19 lockdowns when the survey was conducted in May. Mass drug administration delivery will likely look different during the pandemic from our model of school-based deworming, and we're also accounting for the particular requirements that this will entail. Our plan is to develop a generalized remote monitoring framework and toolbox that can be used to effectively monitor and evaluate our deworming programs safely and with fewer costs. Thanks, everyone. That's the end of my presentation. So I will hand it back over here.
Okay, thank you very much. I think we will just move on very swiftly so that we can do away with the presentations before we engage the participants in a Q&A. So just to remind you, if you have any comment or any question, please use the chat function, put it in there, because at the end of the presentations, that's what we are going to use to actually bring out the questions to the presenters. So we will move on to the next presenter. That's Hugo Legge, who's going to take us through the next presentation on implementar and recipient perspectives of community-wide mass drug administration for STH in Kwale County in Kenya. So over to you, Hugo.
Thank you very much, Dr. Sultani. I will just share my screen. So yes, thank you very much, Dr. Sultani. My name is Hugo Legge, and I'm a research assistant at the London School of Hygiene and Tropical Medicine. So I'm going to share some findings with you today from a study that we have published in PLOS NTDs earlier this year that aim to qualitatively examine what factors drug distributors and recipient community members deemed important in order to achieve high coverage for community-wide mass drug administration for STH. So I'll just do a brief summary of the rationale for this study. So there's emerging evidence that treatment of at-risk groups such as school-aged children and women of reproductive age might not be sufficient to eliminate STH as a public health problem. Community-wide delivery of albendazole has been shown to be more effective in reducing community transmission than school-based deworming, and the feasibility of this approach is currently under investigation in ongoing cluster randomized trials, such as the DOM3 project. Achieving high levels of treatment coverage in successive rounds of community-wide MDA is crucial to achieving a reduction of transmission of STH. However, there's still relatively limited evidence on the acceptability of community-wide mass drug administrations for STH. So to address this gap in the literature, we conducted a qualitative study that was nested within the Tumakia project to investigate the perspectives of implementers and recipients on what factors are related to achieving high coverage for community-wide MTA for STH in Kenya. I'm sure many of you are familiar with this project, but I'll provide a very brief summary. But the Tumakia project was a cluster randomized trial that ran between 2015 and 17 in Kwale County. The trial aimed to evaluate the effectiveness of school-based deworming versus annual and biannual community-wide deworming in reducing transmission of STH. So Tumakia was delivered programmatically using Ministry of Health staff structures, namely community health volunteers as drug distributors and community health assistants as supervisors for those drug distributors. And I would like to thank Dr. Sultani and his team for coordination of these MDAs. Data collection for this particular study took place following completion of the third round of MDA, when focus group discussions and in-depth interviews were conducted with recipients and implementers in the community-wide treatment arms to examine attitudes towards community-wide mass drug administration, its acceptability as a platform for delivery, and what factors were considered related to coverage. So we collected data using two approaches, the first of which was focus group discussions, of which we conducted 32 with community members, where we grouped participants by age and sex. We also conducted in-depth interviews with community opinion leaders. So for example, that included religious and community leaders, and in-depth interviews with community health assistants, who, as I previously mentioned, were the supervisors of the drug distributors, and community health volunteers who acted as the drug distributors. So in advance of coding the data, we developed a conceptual framework that maps out the key components of community-wide mass drug administration. And I'll come back to this in a bit more detail in a second. Coding of the data was carried out by two primary coders with a subset of transcripts double-coded and evaluated for intercoder reliability. After we finished coding the transcripts, data aggregation queries were used to develop case memos, which were then used to form the basis of our analysis. So before moving on to the results, I just want to take a minute to go through our conceptual framework, as it played an important part in shaping our analysis, and I think it's useful as a visualization. It's useful to see a visualization of the pathways through which we conceptualized coverage being achieved during a community-wide mass drug administration. So if we start at the end of the framework, we identified two key factors that ultimately determine the coverage of an MTA. The first of which is uptake. Essentially whether or not an individual decides to take a tablet when they're first presented with it. Well, not first, but when they're presented with it. And this is sometimes also referred to as compliance. And the second factor, which is a prerequisite for uptake, is reach, which describes whether or not an implementer is able to make contact with a given household and to offer individuals within that household treatment. So it perhaps might seem as if the difference between these two factors is somewhat minimal, but the drivers that promote or inhibit them are quite distinct. So it's a useful conceptual distinction to make. So if we start with uptake and we think about the immediate factors that influence whether or not an individual decides to accept treatment when offered, there's a number of different immediate factors that we could consider. And this could include recipient awareness, whether or not the recipient was aware of the program in advance of being offered treatment. Recipient trust, so that includes trust towards the individual that's offering them treatment, but also more broadly trust towards the organization that is delivering the MDA. So for example, the Ministry of Health. Recipient demand, of which there are sort of several layers. So for example, does an individual believe that the disease actually exists? If they believe it exists, do they believe that it's possible that they as individuals might have it? If they believe that they have it, do they believe that the symptoms and the health impact of the disease is sufficient to warrant treatment? And if all of those things are true, do they believe that the treatment being offered is actually an effective cure for the disease? And then related to demand and trust is this idea of perceived safety. So do recipients think that the drugs are safe? Do they anticipate negative health impacts or side effects? So to an extent, all of these factors have to be satisfied for an individual in order for them to accept treatment. And the inputs and activities that implementers can use to promote trust and demand and awareness are engagement activities, which sometimes are referred to as sensitization, and the sort of quality and extent of engagement activities that are undertaken. And then in addition to that, the capacity and motivation of implementers who are actually delivering the drugs. So if we follow this back to the initial project inputs that might impact engagement activities and the level of motivation and capacity of implementers, we've got our sort of core project inputs that includes supplies, which might involve uniforms, appropriate weather attire, payment for distributors. Obviously, it could involve transport, which allows distributors to reach communities. Training capacity so that distributors are able to be trained to conduct the MDA. And then also workload, which is essentially, or workload assignment, which describes the number of households that any given CHV has to deliver drugs to, and also the number of CHVs that supervisors, the CHAs, have to oversee. So we can see that this broadly describes the inputs, activities, and intermediate outcomes that lead to uptake. If we return to reach, we can see that there are two immediate factors that determine whether or not a household can be reached. The first of which is the accessibility of the household. So how is it rural? Is it remote from other households? Are distributors actually able to access it? And the second of which is recipient availability. So if a household is able to be accessed, are the individual members of the household actually present in order for them to be offered treatment? And we can see that recipient accessibility is something that's directly mitigated by the level of project input. So for example, we can see that transport and workload, so the amount of households that a CHV has to deliver to, would directly impact the accessibility of a household. And for recipient availability, we might consider that their prior awareness, which is itself a product of the level of engagement activities, would lead to whether or not they were available at the point of contact. So we also considered a range of contextual factors that exist sort of outside of the immediate control of implementers. In the interest of time, I'm not going to go through each one of those individually. But for example, we can see at the top right, oh, maybe I have a pointer here actually. There we are. We can see at the top right that the physical community characteristics like geography would impact the accessibility of a household, and the cultural or socioeconomic characteristics of a community, such as work habits and schedules, would affect recipient availability. So once we finished a first draft of this framework, we used it to finalize a code book that basically was the basis of our coding of the data. So we use this as sort of like a map to guide our coding of the data. So let's have a look at some of the results. So following coding and analysis, we stratified our results according to their impact on reach or uptake. For reach, we identified 3 priority domains, which included an adaptable implementation strategy and efficient supply chain, community availability, and implementer training and motivation. And for uptake, similarly, we identified 3 domains, and that included perceived safety, rumours and beliefs, perceived effectiveness and need of the drugs, excuse me, and community engagement activities, community awareness and knowledge. So I'll go through each one of these domains, hopefully briefly, but each one in turn to sort of describe what the findings were in relation to them. So if we start with an adaptable implementation strategy and efficient supply chain. So these are excerpts, or this is an excerpt from the data itself. So I can say that these days are not enough. Every time they ask why these villages are not always covered, I told them I was doing it alone, and it's a big village. So it's either they increase the number of days or they increase the CHVs. So among CHVs, discussions around implementation invariably focused on workload assignment and the number of days that were available to complete their targets. CHVs directly linked excessively heavy workloads to lower reach, as less time was available to cover all of the assigned households or perform revisits for absent household members. Poorly sensitized community members were also highlighted by some implementers as reducing reach, as CHV's time was eaten up by the need for additional doorstep sensitization, which then impacted their ability to complete their workload assignment. So for community availability, if only one person in the guide were to distribute to all houses, maybe they arrive at around noon, when most women go to the shamba, and the children have gone to play, so it was difficult. That was from a community member. You can revisit even 3 times, but you won't find them, because in our area, if a man is not employed, he goes to the quarry and mines stones. So I think these 2 quotes highlight that essentially both implementers and recipients perceive the availability of community members as a key determinant of reach. So community availability was hindered by competing responsibilities, including school for children, and for adults, casual labour or employment that led to members being absent from the households at the time of the drug delivery. Additionally, entire migrations by households was seen to be especially time-consuming by CHVs, as it sometimes took multiple visits for them to even just confirm that the household had in fact migrated. So an incredibly inefficient use of drug distributors' time. And then finally, in reach, we've got implementer training and motivation. CHVs were motivated to participate in the MDA by a number of factors, including belief in the effectiveness of the intervention, which provided them with the opportunity to improve the health of their community, the sense of self-efficacy in carrying out their roles, and the level of financial and non-financial incentives, such as knowledge and recognition offered to them by participating in the intervention. Effective training identified by respondents included the use of technically and culturally tailored training resources, as well as the avoidance of repetition in training materials. And essentially motivated and well-trained CHVs were seen to be more effective by CHAs and to be more likely to be retained in employment for future MDAs. So if we move on to uptake, perceived safety, rumours and beliefs. So some swallowed the tablets, some didn't. Those who did not, some said they had heard rumours that the drugs are meant for family planning and they can cause strokes and elephantiasis. And that was a youth female community member. When one is given the drugs, they just take the drug to end the conversation. And then later they throw it because the drug may be the Illuminati wanting to take their blood. And that was also a community member, a youth male. So lack of trust in the stated purpose of the drugs being offered was commonly referenced by respondents as a reason for community members not to accept treatment. Past negative experience of MDAs for other diseases will also raise a reason to mistrust treatment with albendazole. Community members were far more likely to express trust in implementers when they were selected from the community in which they were distributing. And in addition, professional uniforms such as branded t-shirts and hats, as well as a general respectable appearance, were seen to be positive attributes that were likely to engender trust. So if we move on to perceived effectiveness and need, we've got two sort of varying opinions here. I think it was fine because many people have less problems since we had children with worms. And after taking the drugs and slept at night, the worms were getting out and now the problems have ceased. So the drugs have helped people a lot. And that was from a community opinion leader. But the drugs were given to everybody. How did they know each and every one has worms? The process was not perfect at all. Maybe I'm being treated for an illness I don't have. And that was from a male community member. So despite the rumours and fears, most recipients appeared to perceive MDA as effective for treating helminth infections based on their own or others' previous experiences. And this was cited by many as an important reason for treatment uptake. Where there was a lack of belief in the need for treatment, this stemmed from either a lack of understanding of the purpose of the MDA or a belief that STH is a children's disease and as a result adults are not affected. And then lastly, community engagement and activities, community awareness and knowledge. In the interest of time, I will not read the quotes because I see I'm running short, but essentially community engagement was seen to be key by both implementers and recipients to dispelling rumours, promoting trust, generating demand, and essentially ensuring high overall uptake. The most crucial aspect of a successful engagement strategy was seen to be the leveraging of existing community leadership structures to disseminate knowledge. So the use of village chiefs or of religious leaders to further disseminate messaging about the MDA. Beyond engagement activities, though, community members expressed expectations that CHVs should at least be able to provide information on aspects of the drug delivery. And you can see in the second quote there that essentially poorly educated CHVs were linked by some respondents to an unwillingness to accept treatment. So a primary objective of ours when we were undertaking this study was to ensure that the findings were directly applicable to national programs. So we took our 6 domains across reach and uptake and synthesized them into 4 sort of key areas of recommendations that could be applied to programs to improve reach and uptake. And I'll just run through those very briefly now. So the first was development of an efficient and reasonable workloads. The second was motivated and appropriately selected drug distributors. The third was developing effective capacity building strategy for implementers. And the fourth was design of a contextually relevant community engagement strategy that leverages existing community structures. So development of efficient and reasonable workloads is comprised of a couple of different strategies, but essentially ensuring the sufficiency of drug distributors, supervisors, and other necessary materials in order to reach households. Planning distribution strategy so as to maximize the availability of target communities, so taking into account known norms about migration, working habits, school attendance in order to maximize the possibility of catching household members. And then lastly, develop adaptable implementation strategies that respond to feedback from the needs of implementers and recipients. And essentially the last one is just a reference to monitoring, I think monitoring and evaluation essentially, and to perhaps process evaluations which allow learnings to be taken on board and to adapt implementation as programs sort of move forward. So for motivated and appropriately selected drug distributors, That involved developing an effective recruitment strategy that ensured there were necessary financial and non-financial incentives that allowed the recruitment of effective drug distributors. And also, and this is really crucial, I think, is the use of drug distributors that live and work in the area in which they are delivering drugs, as this was seen as very important, and it's why it's in the title of the presentation. Is very important for engendering trust between implementers and recipients. Developing effective capacity building strategies for implementers. Essentially, this is trainings and how to deliver successful trainings from the perspective of CHVs, so the avoidance of overlap with ongoing responsibilities, and taking into account the local context. And then lastly, and this is my last slide, Dr. Sultani, so I'm almost finished, design of a contextually relevant community engagement strategy that leverages existing community structures. So essentially the two strategies here are to leverage existing community structures as part of engagement strategies, but also take into account the experiences that communities may have had of past MDAs with different drugs. As in the data that we analysed, we saw quite a lot of conflation by respondents in terms of side effects that were related to drugs for different diseases, so such as praziquantel, schistosomiasis. So in conclusion, we've presented some key strategies that could be directly applicable to national programs that are transitioning towards community-wide treatment for STH, which could be used to improve reach and uptake and ultimately coverage. And as part of doing this study, we saw that the challenges that we identified were similar to many found in the wider literature for other PC NTDs. So that suggests that there's a good possibility for greater collaboration between PC NTD programs that could be beneficial for all. Thank you very much. The acknowledgements. So thank you very much to our participants and contributors, partner organizations and authors. That's it. Thank you very much.
Okay, thank you, Hugo. Although you went over your time a little bit, so
I am sorry. I apologize. I saw your screen come on, so I was getting nervous.
Yeah, I was trying to communicate to you because I really wanted us to also listen to Sanjay.
Yes,
and
I do apologize.
Sanjay, please keep time because we are now eating into the Q&A, and I believe that one of the objectives is to be able to get insights also from the other participants. So I can see your screen is already up, so take it away.
Thank you, Dr. Sultani, and thank you everybody for your time and then contribution today. This is Sanjaya Dhakal from CWW in Atlanta. We would like to share CWW's experience in building NTD capacity for community-wide surveillance of STH and SCH in Kenya. First, I would like to introduce my co-presenter, Cara Tupps. Cara plays a very important role at CWW as Associate Director for Programs. Now, she will lead you to the first component of our presentation in collaboration and partnership in Kenya. Then I will come back to discuss some of the methodology and results. Cara, please take it over from here.
Thanks, Sanjay. So as he introduced me, I am the Associate Director of Programs, and I work very closely with Dr. Sultani and his team in our programs in Kenya. So just a bit of an overview to start us out on STH and Schisto in Kenya. They have had ongoing school-based deworming since 2009. And according to the last impact survey, which was conducted in 2017, among school-going children, it was estimated that about 13% of children were infected with STH, and then around 2% with Schisto. And this has been a huge reduction from the baseline survey that was conducted also among school-age children. So the next step for Kenya was to roll out the breaking transmission strategy for 4 different NTDs, of which schisto and STH were included. And in order to do that, we needed some new data. We needed some community-wide data and also data at a level below the national level. So those previous impact surveys were conducted for the whole of Kenya, and they were only focused on the schools. So our implementing partners in Kenya have been, of course, Dr. Sultani's team with the Division of Vector-Borne and NTDs, and also the Kenya Field Epidemiology and Lab Training Program. Their goal is to train staff within the NTD department, or within the MOH rather, for field epidemiology, and so it was really critical to partner with them. Also, the Kenya Red Cross, FENET, and the county level public health staff. We, of course, have many other technical and advisory partners in Kenya and internationally, but these are our main implementing partners. And so CWW's goals for this partnership with the MOH has been to build capacity for NTDs within the MOH, human resources, and also knowledge and that sort of capacity, but to also build up the FELTP program in NTD surveillance and data management. So some of the ways that we've done that include partner coordination and mapping different surveillance activities across the country. Also promoting the development of an NTD specific curriculum within the FELTP program, and also assisting the NTD program in conducting surveillance activities specifically for community-wide prevalence of STH and schisto. So as I said before, the previous impact surveys for these diseases had been focused on schools and mostly at the national level. So there was a need, a gap for subnational level surveys and also community-wide prevalence in order to get that full picture of STH and schisto epidemiology to work towards the BTS. So our plan was, along with the MOH, to conduct surveys in Narok, Bomet, and Vihiga counties for stool-based surveys specifically, looking at STH and S-Mansnai. Those are the green highlighted counties on the map there. And then we also plan to conduct surveys in Bungoma, Trans Nzoia, and Kakamega with the addition of urinalysis, because those were targeted by the MOH as being suspect for schisto endemic counties. So in those counties, since schisto planning happens at the ward level, we also plan to take any wards which come up positive for schisto when we do the county level surveys, and do a ward level survey to have data at that level, so to inform program planning. And now I'll give it back to Sanjay, who will cover the methodology of these surveys.
Thank you, Cara. As some of you might have already known about integrated community-based survey for program monitoring, which was first implemented in Bangladesh. In general, we assume that consistent intervention in school-age children and preschool-age children in some of the countries is sufficient to eliminate STH as a public health problem at community level among all age groups. So that is why ICSPM aims to evaluate the prevalence in all age groups, preschool age children, school age children, and adults at community level. And we know data-driven monitoring and evaluation plan needed to truly achieve these goals. For that, of course, we need motivation from countries who want to achieve community-wide elimination. Now we are piloting this ICSPM in Kenya to support monitoring and evaluation for breaking the transmission strategy. Next slide, please. ICSPM relies on cluster sampling method to select 30 villages from a county or a district based on proportion of population on each village, which means higher the population in a village, larger the probability of being selected as a cluster. We divide whole county into 3 risk groups: preschool age children. For Kenya specific, the age is 2 to 4 years old. For school age children, 5 to 14 years old, and anyone with at least 15 or more. At least 332 individuals are enrolled in each risk group. In recently adapted ICSPM methodology, we're planning to oversample for cysto to account for ecological variations. Now back to Cara again.
Thank you. So in conducting these surveys, we wanted to make sure that it still fit into our broad goals, which I highlighted earlier, to build capacity. And so we developed sort of a cascade training model for this methodology. We brought 2 of the Kenya NTD program staff to Atlanta to undergo intensive training on this method. And then they were able to facilitate trainings both among their colleagues in the national NTD program, but also at the county level once we conducted the surveys. And we're continuing this model now. We've trained 3 additional staff who will lead the 2020 surveys. Of course, we've had to do that virtually. And when we're talking about implementation in the field, I think it's important to highlight the actual nitty-gritty things that contributed to success. So the first thing is sensitization at the county level and making sure that the county staff are aware of the benefits of this activity, and their buy-in is really essential. So we always have pre-survey meetings with the county staff and also the CHVs and public health officers who are involved, so that everybody knows what their roles are and how important it is to get engagement among the participants. But also the post-survey meetings to disseminate results, but also share challenges and feedback from the people involved in the survey are really important, so that we can continue to improve and not repeat our challenges over and over. So the national NTD program staff were able to lead the survey teams, and that was great because they've been trained intensively on the methodology, but the CHVs and the public health officers served as the enumerators, and I think their involvement was just as important because they, as Hugo said earlier, the CHVs are often from those communities. These are their neighbors that they're engaging, and they have been able to really encourage participation and producing samples for us. So our response rates have really been encouraging. And part of that's because we make sure that whatever clusters that are selected, whatever villages we're surveying, we use the CHV who works there and is often living there as well. And then the third thing has been the capacity building among the lab staff. I think oftentimes we think of diagnostics as very technical, but it's also important to have good human resources who are trained and who are able to work in a setting with limited resources and limited time often. So in order to do this, we recruited lab staff from the county offices themselves, from the hospitals and clinics. And part of the motivation for participation is they get to sort of master the skill of Ketukats, which is not something they get to practice often for most of them. And for some of them, it's a completely new skill. But we also have been bringing 1 to 2 staff from one county to the next to sort of build their managerial capacity. And the idea here with this whole capacity building model is that eventually, you'll have a pool of people who've been trained and are experienced, and this can sort of become a routine activity in the counties, and there's no need for international or even national intervention, or at least the level of involvement is greatly reduced, and this just becomes sort of a routine surveillance activity for each of the counties. And then to tie us off, I will give it back to Sanjay, and he will present some of the results from the first survey that we completed.
Thanks, Cara, again. We surveyed Viga County in last year in November. So as you might have known, previous school-based surveys which are powered to national level suggest the prevalence of STH in Viga County is somewhere in between 20 to 50%. However, our survey in November with a statistically representative sample of Viga found this prevalence of STH to be below 10%. Which indicates, in terms of intervention and then WHO's guidance, which indicates that MDA could be reduced to once every 2 years in Viga. Although ICSPM is not powered to sub-county level analysis, it allows for exploration of spatial distribution to guide further investigation into potential hotspots and appropriate intervention. So we explore at sub-county level, as you can see in the map here in the slide, these two sub-counties still drive the prevalence a little higher than the other three counties in the other three sub-counties in the Viga County. So it means the program of the entity program office or whoever the partners want to work, they might want to dig into the Savati and Luanda sub-county and may explore some of the reasons why they are still kind of persistent if there are infections in there. Now, next slide. And just to mention that we also scanned for cysto in Viga County, which we could not find any cysto there. And at the end, we would like to thank you for all the partners, all the stakeholders, and then donors, funders, technical advisors who supported us in this mission in their different capacities. Thank you very much. Now back to Dr. Sultani.
Okay, thank you, Sanjay, and thank you for keeping within your time. So now I think we will move straight to the Q&A session, and to actually moderate this, I will take it to Girija, who will read out the questions that have been posted into the chat, and then we will probably direct them to the various presenters so that they can respond to them. Over to you, Girija.
Excellent. Thank you, Dr. Sultani. Thank you to all the presenters for wonderful presentations. It's nice that the questions are actually organized in the chat box. So I'm going to start with the first 2 or 3 questions to Andrew. So Andrew, we have a few questions on your presentation here. So for example, how did you deal with the sampling of participants, especially making sure they're representative in terms of their geographic distribution within the sample sites? So Andrew, I'll read a couple of more questions and I'll give you a chance to respond. The second question to Andrew is 83% of the interviews were done on first call. What happened to the remaining 17%? Did you have situations where parents refused to respond? And if yes, were there reasons for their refusal? So maybe I'll stop here, Andrew, and see if you'd like to comment.
Sure. For the first question about a representative sample in terms of geographic distribution within the sampled sites, we did find it difficult to ensure geographic representation within the communities due to reaching all respondents over the phone. Normally with in-person surveys, we would be able to account for that a little bit better. However, we did find some correlation between parents we spoke to of non-enrolled students and enrolled students and their distance from the school or from the center of the community. And so, you know, to the extent that we do know, we feel like we had some representation of respondents from across the community. But it is something that we reported in our results that, isn't necessarily something we could fully account for. For the second question, 83% of interviews are done on the first call. So we, just a few stats on this, 83% were done on the first call, 9% on the second, 6% on the third, and 1% on the fourth. Most of the callbacks after the first, or second or third call were due to parents being busy with their daily duties or work, etc., but asked us to call back. We did have a small amount of outright refusals, of less than 1%, which were mostly due to either, just not having time, not being interested, or there were some reports of parents with some fear of fraud and not being willing to share information over the phone.
Thank you for that, Andrew. We have a few more questions for you. Martin Homero would like to know, in CIA, there were 2 drugs administered, praziquantel and albendazole or mebendazole. How did you ensure that one drug was not confused with the other through the phone interview? And did you attempt to validate praziquantel coverage in that county? And I'll follow up with one more question. Cara would like to know, in Narok County, did you account for seasonal migration patterns?
Sure. So on the first question, we did attempt to validate for PCQ in Siaya. However, due to drug supply challenges for the MDA that took place in March, very few schools in the county received drugs. So the results of the survey that we did were inconclusive. That's why they weren't included in the presentation. As far as ensuring confusion during the phone interview, we have a separate survey module for STH, or for PCQ and albendazole. And so the PCQ module only displays for schools that are known to treat for both, based on our program. Without the in-person survey, we weren't able to show the drugs or the pictures of the drugs as we would normally. So we relied on the knowledge and the descriptions of the callers, which was part of their training, to describe the STH treatment and the schisto treatment separately. And then, sorry, for the second question, in Narok County, did we account for seasonal migration patterns? We didn't account for seasonal migration in this survey. That's a really good point, though. Yeah, it's not something that we've looked into. I'm with the lockdowns and the movement restrictions, I'm not sure how much the effect would have been this time around, but it isn't something that we accounted for.
Excellent, thank you, Andrew. A couple more questions, and then I will move on to questions for Hugo, and then maybe I can circle back to you after that if we have more questions. I think people are interested in your protocol or methodology of your last covered survey with COVID-19. Yes, so people would love if you're able to share your methods. Duncan would like to know, for parents with more than one child in school, did you ask about each child or if any child took the drugs? And then Alex Jones would like to know if you note that 15% of respondents were out of school children, noting the small sample size, did you analyze reach or compliance for this group?
Sure. So for the first question, we do ask specifically about each child in the household, each child within the target age group. So the survey loops around depending on how many children are in the household based on the response earlier in the survey. And then for the non-enrolled children, we did disaggregate for program reach and surveyed coverage. As I mentioned, the coverage was about 83% in both counties overall. For non-enrolled, it was 25% in Narok and 17% in Siaya. which obviously is quite a bit lower, but is consistent with results we've seen in the past as far as the difference between enrolled versus non-enrolled or overall versus non-enrolled children.
Excellent. Thank you so much, Andrew. I'll circle back. There are a couple of more questions that I see here for your presentation, but I'll circle back with you. If that's okay, Dr. Sultani, I'd like to move to questions for Hugo's presentation. So Hugo, Cara would like to know if there was an analysis by gender, age, role, or status in the community. And if so, were there any trends in acceptability and demand across those lines?
Yeah, that's a very good question. So that's something that we were considering doing. In the end, I think essentially we felt that stratification of analysis by age and sex, specifically relating to community members. So we had 4 distinct groups, which was youth, female, adult female, youth male, adult, youth male, adult male. And ultimately, I think we felt that if we performed the analysis stratified by these groups, we would be compelled to obviously report the results in a sort of comparative perspective, so sort of contrasting the different perspectives from the different groups. And I think although we would have liked to have done that, I think we felt that it was perhaps slightly beyond the scope of the paper, which was already, I mean, if you go and see the paper, you'll see that it's quite long, was already very sort of wide-ranging. I think in terms of just running the analysis without a specific intent to stratify by group, we did notice some variations in some of the responses. So for example, I mentioned during the presentation that some respondents flagged doubts about the purpose of the treatment and specifically related it to fears about sterilization and forced family planning. And those fears were more likely to be voiced by female respondents from both age groups than male respondents. But in general, I don't think we saw, I don't think we felt that there was significant differences between the perspectives that were being shared within the different community focus groups when we were doing the analysis yeah, it's not something that really jumped out at us when we were doing it.
Thank you, Hugo. A couple of more questions for you here. Martin would like to know if you employed the realist evaluation, context, mechanism, outcome, or was it an application of the principles that underlie realist evaluation? And then Sammy asks, or he says basically regarding community availability, timing of the household visits might be necessary to consider. There are certain times when most community members may be available in the homesteads.
Yeah,
maybe that was probably more of a comment.
Okay, cool. Yeah. So the approach that we used, I think, was grounded theory with a sort of inductive approach to creating the framework. I'm not. I have to admit that I'm not very familiar with all of the different theories and approaches that are available in the field of qualitative research. So that may be a question which would be better placed towards our senior authors. But yeah, so we used grounded theory to develop the framework and the code book. And then for the comment, I agree absolutely with the comment.
Excellent, thank you. I think, well, Duncan has a question about the definition of community health volunteers / drug distributors known to the community. I imagine this might have been, yeah. Are you able to respond to that, Hugo?
as I understand, the drug distributors as community health volunteers would have been previously known and known to the community members. And they, by and large, were selected from within the communities in which they were distributing. So I think their identity and the capacity in which they were acting would have been clear and known to community members. I'm not sure if that answers the question though.
Okay, we'll see if the commenter circles back with an additional question. This was Duncan
Sure.
Who asked the question.
Okay.
And I do see that there's been a bit of an exchange, which is wonderful, on the chat box. I believe there was a question about, I think this was to the CWW presenters, how long after MDA was the survey in Vihiga conducted in November 2019? And I think both, Sanjaya and Sultani have responded to this question in the chat box. I can call out Rita's question, Rita's response about overcoming the issue of the 6-month gap between MDA and survey. So Sultani responded to Rita's question about the gap between the survey and the MDA, saying there are multiple unprogrammed implementers of MDA in STH endemic areas. We're still doing MDAs at different times. And so the 6-month gap is unlikely in the majority of the surveyed areas. And so Rita would like to know how we might plan to overcome that issue. I don't know if someone from CWW is able to respond, or perhaps
Yeah, Girija, let me just address that. I think that's a very important question coming from Rita. You'll realize that we have had a big problem with coordination around STH and schistosomiasis implementation in the country. And so we've been having a lot of surveys going on that are not reliable. We've been having a lot of unprogrammed MDAs going on all over the place because it's a kind of like a free-for-all situation. So this was because the NTD, the National NTD program, was not providing leadership. We were over-relying on the school health program, school-based deworming activities, which were ongoing. But on realization that we were not achieving our goals for control and elimination, we moved ahead and developed the breaking transmission strategy, which established a national STH and schisto control program. So what we are doing now is we are now pulling everybody into this coordinated framework so that we can now organize the surveys and also organize the MDAs so that they can give us the kind of results that we want to get. We have experienced quite a bit of success, although we are still finding that there are still quite a number of players who are operating outside of the framework. As a program, we are moving fully into the breaking transmission approach, which we are now scaling up, and we are hoping that as early as the end of next year, we should have all the endemic target areas under this strategy. So you'll find that some of the surveys, although they have indicated that the prevalence is low, we cannot really believe that that is the situation, because in some places when we go there to survey, we find that actually even maybe the previous day or the previous week, there was a group that came in and dewormed. So that is what the program is shooting to achieve with the establishment of a national STH control program. Thank you, Girija. Maybe we can move a bit faster because we just have under 10 minutes to conclude the Q&A. Thank you.
Okay, no, thank you for that, Sultani. I think we've sort of run through the initial list of questions here. I think Duncan, who had asked the question about the community health volunteers definition, Hugo, he's circled back, I believe, and he asks if all these CHVs are known to the community, how did you analyze to conclude that the community trusts the people they know?
Yeah, that's a very good question. Two parts there. So not although the majority of drug distributors were sourced from the communities in which they were delivering drugs, this wasn't quite 100%. So there were some in smaller communities, there were drug distributors might be asked to distribute into separate communities. So there would have been some instances where community members were receiving drugs from people that may not have been known to them. But also in addition to that, respondents often, in a couple of, off the top of my head, in a couple of different coded parts of the transcript that I can remember, respondents hypothesized themselves about how communities would have reacted had a stranger showed up to offer them treatment. And specifically said there will be resistance if we didn't know who they were, then there would have been resistance. So that's how we sort of arrived at that conclusion from the data.
Excellent. Thank you for that, Hugo. I'm going to circle back to Andrew. I believe there are a couple of questions that I skipped. Andrew, if you wouldn't mind, let's see. Oh yeah, so Andrea asks, what were the losses seen by having the parents conduct the survey and reducing the questions? Was the ability to ask more in-depth and follow-up questions diminished?
Yeah, great, great question. So the survey still included sort of the key indicators that we report on and are used as sort of our key drivers of program improvement and to evaluate coverage, but did drop a few follow-up questions. And I think what you said, more in-depth and follow-up questions, like those are the areas where we trim the survey. So things like asking follow-up questions if a child did or did not receive, or sorry, did receive the drug or did swallow the drug, about who exactly gave it to them, or you know, asking questions, follow-up questions about why they decided to swallow the drug, what were their reasons for doing it, things like that, were dropped from our normal survey in order to streamline and get sort of those key indicators that we look for.
Thank you. Thank you, Andrew. We're about 5 minutes left. I want to give Dr. Sultani a few minutes to provide some concluding remarks before we end the presentations.
Okay, thank you very much. I also had a few questions, but it looks like time has caught up with me. And specifically, I was hoping to ask Andrew about the coverage, because we have consistently seen a very high coverage of above 80 from the surveys that are conducted by the school health program. But when we look at the figures, we find that in actual sense, when we look at it in terms of covering the target population, the coverages, the percentages are very low. In the past, we have seen that kind of trend, where when we now subject the numbers to our denominators, we get coverages very low, sometimes even lower than 50%. And we probably think that could be the reason why our program has not been able to achieve the target, the targets for control and elimination. So I would have been very keen to know what the denominator which was used was, because sometimes when this kind of information is disseminated on global platforms, then it provides conflicting information. And sometimes we find that we are dealing with information that, like this is the first time I'm coming across these results as the national program manager. And I think it might not be very good for the national program when we find these kind of figures that are not accurate being distributed out there or disseminated. So I think because of time, I just wanted to really thank the presenters who have given very useful insights into the STH program and the work that has been done. As I said in the beginning, we rely as programs on these kind of operational research work to be able to make our programs better. I can say that our breaking transmission strategy, which is actually poised to make very big changes and differences in the world, is directly inspired by the work that has just been presented by Hugo around the Tumikia study. We drew a lot of lessons from it. We actually looked at some of the negative aspects and positives. We adapted that. And I saw Rachel Pulan on the call, I think on the meeting. I think she played a very important role in informing the program. And that's the direction we have taken. We have learned quite a bit from that. We are also very happy to look at the approach that CWW is taking in the surveys, which involves, actually there is mainstreamed capacity building of the program in it. And we are very happy to see the kind of results that we are getting. So I think with that, and of course, some of the contributions that have been made by participants, we are definitely going to pick out some of the key lessons that we can draw from so that we can move faster towards controlling STH and probably eliminating schistosomiasis in areas which it can be eliminated in Kenya. Maybe just as a concluding remark, I just want to inform those who are not aware that as Kenya, we have gone a step forward, and we are very keen on breaking transmission of these, STH and schisto, which is actually beyond the global goal, but we would like to reach that goal as fast as possible. And I think with that, with those very many remarks, I just want to thank everyone once again. I really want to thank CWW, specifically Girija, for putting this together. I think it's very important for us to keep on having these kind of discussions, engaging, so that we can learn from each other, peer-to-peer learning, and probably be able to, eliminate some of these NTDs, not just STH and schisto, from our countries. I know that there would be a lot more to be said, and many more people probably have other issues to discuss, but I think they will come in the next meetings. So with that, probably I would just like to bring the meeting to a close and thank everyone for making time to attend this meeting. So thank you very much. And I think at this point, unless Girija, there are some concluding remarks, I would like to maybe, I can see you're nodding, maybe you can take it over and then you close. Thank you.
Thank you. Thank you so much, Dr. Sultani. Thank you to all the presenters. Thank you to all the participants for your wonderful questions. We will follow up in the next week or so with a link to the slide deck and the webinar recording. So please stay tuned for that. In the meanwhile, if you have suggestions for future webinars that the STH Coalition Secretariat can host, please do drop me an email at gsankar@taskforce.org. And finally, thanks to Matt Ferret for helping us manage the meeting. Thank you and have a wonderful day. Take care.